As I return on the recording, I'd like to introduce you to our first speaker, Michael Healy. Michael gave one of the most popular talks at our annual conference last summer, and we are pleased to have him launch the series for us. He also has a couple of patients with him who he will introduce during this talk, and they will share their experiences as well. Several of you sent in questions ahead of time, and I thank you for that. If you didn't, you can still ask written questions through the Q&A button that you should see on your screen. We will answer as many questions as we can at the end of the talk, and I'll be checking those questions while Michael is speaking, and I will be presenting those to them when he's done. So I'm going to flip this over and give Michael control of the screen, and he will be presenting now on physical therapy for Marfan and Ehlers Danlos. Michael?
Thank you, Eileen. Can everybody hear me?
Well, if they can't, they will have to send me a message.
Okay, good. I took off the headset because it was rubbing, and a couple of people were mentioning that the fabric sound was irritating to them. So I'm going to the speaker on the phone. So I'm hoping that you can hear me well.
Okay, they're saying that they can. Oops, they're saying that they can.
I would like to thank the Marfan Foundation and Eileen for letting me speak to you today. And I hope to answer as many questions as possible by the end. I will be doing my lecture, and I will have in the middle of the lecture 2 of my patients speaking with you, one with Ehlers Danlos syndrome and one with Marfan syndrome. So anytime you want to stop the presentation, Eileen, I don't have.
I think you have the remote control now.
It's not letting me switch any pictures.
Oops.
Oh, there we go.
Was that you or me?
I think it was you because I got no control.
Okay. It said waiting for Michael Healy to control your screen, and there you have it now. So you should be all set.
All right, there we go. Okay. All right, our topic is going to be a manual physical therapy and therapeutic exercise approach to Marfan syndrome and Ehlers Danlos. Currently, I have 2 locations for my physical therapy office in Rhode Island. We're going to be opening our 3rd office in Warwick, Rhode Island pretty soon. That's just basically what this slide is telling you. This is my educational CV. I received my bachelor's degree in physical therapy from the University of New England in 1986, my master's in business administration from Bryant University in 1997, my certified personal trainer certification and a certification in sports nutrition in 2003, a golf fitness instructor certification in 2007, my diplomate and doctorate in osteopathic manipulative theory and practice from the Osteopathic College of Ontario in 2008, and my clinical doctorate in physical therapy from Simmons College in 2012, as well as an integrated osteopathic manual therapy certification in 2017. I have nothing to disclose. I have no actual or potential conflict of interest in relationship to this presentation. Discussions in this presentation are for general information purposes only. All patients have verbally and in writing agreed to participate in this presentation. All patients have signed waiver forms allowing me to utilize their pictures in this presentation and any presentation that I might use in the future. Therefore, there are no HIPAA violations. The goals of this presentation is to understand why posture and biomechanics are important in positive patient outcomes, understanding why the combination of manual therapy and therapeutic exercise lead to better patient outcomes versus therapeutic exercise alone or manual therapy alone. And at the end, what should you look for in a physical therapist treating patients with connective tissue disorders? Alan, I can't control the screen now. Somebody was controlling the screen. I'm sorry that the presentation is stalled. I can't control the screen right now. All right, connective tissue disorders. Collagen is the most abundant protein in the human body. Collagen provides the structural strength of all human tissues. It is the glue that holds us together. When muscles, ligaments, organs, and bones are built with defective collagen, it will cause systemic weakness and instability. Ellen, someone's messing with the screen. It's not allowing me to let the slides go forward, and some of the slides are jumping 2 or 3 at a time. All right. Muscles and ligaments function. Normally, muscles should always be off tension. You should only use your muscles when you want to actively contract them. Your ligaments, they should always be on tension, and they should be used for joint stabilization. What happens with patients with EDS, or Ehlers Danlos syndrome, hypermobility, and Marfan's, the muscles go on tension continuously in attempts to co-stabilize the joints and your spine. The ligaments go off tension, providing no stability. The goals of manual therapy: to restore maximal pain-free movement of the musculoskeletal system and postural balance. In Ehlers Danlos, Marfan's, and hypermobility syndromes, the muscles, when they are on tension, will result in pain, muscle tightness, muscle spasms, trigger points, and weakness. Ligaments, when they go off tension, they will cause joint pain, joint instability, subluxations, and/or dislocations. Manual physical therapy. The goal of this is to reverse this process. We want to put the muscles off tension and put the ligaments on tension. Once the structures are balanced, therapeutic strengthening, stabilization, toning, cardiovascular, and proprioceptive exercises should begin at that time only. Specific stretches for muscle tightness, muscle spasms, trigger points will begin once spinal segmentation or joints are stabilized. You do not want to start stretching if your joints are not stabilized, because that will cause more instability. This is what a patient without connective tissue disorders house looks like, the outside of their body. Everything is 16 on center. A patient with Ehlers Danlos syndrome, their house on the outside looks the same as a typical house for a person with non-connective tissue disorders. Except our EDS patients tend to look younger, 5 or 10 or 15 years younger, and they tend to have a lot less wrinkles because of their skin is a little more stretchy. Now in the typical house, the frame and the foundation are built with good 2x4s, good 2x6s, and good 2x8s, and everything is built 16 on center, which is a construction term to say that everything is built squarely and strong. And our EDS population, or our hypermobility population, and our Marfan's patients, their structure is built with defect, particularly of the collagen, which is, I talked about earlier, is the protein that holds our body together. It's the glue that holds your body together. Basically, the 2x4s that are holding Ehlers Danlos patients together and Marfan's patients together with hypermobility, their 2x4s, 2x6s, and 2x8s are more termite infested. And so what happens if you don't get good therapy and you don't exercise, your house will basically fall down. This is a picture of Ned. His name is Edward O'Donnell. He's going to be speaking with you today. He's the gentleman on the right. And there's a picture of Carla, who's one of our receptionists here at Healy Physical Therapy. She's one of our admin staff. And she wanted to get a picture with Ned because she just thought it would be cute. And this is a picture of myself with Ned before he does his exercise program. Now, it's very important that you understand good posture versus bad posture when you're standing or sitting or lying down. A typical head weighs 10% of a person's body weight. Now, every inch your head goes forward, the first inch that your head goes forward, it increases the pressure on your neck by 20 pounds. So in this example here, the person where you see the 12 pounds above the head, that patient weighs 120 pounds. Their head weighs 20. So for the first inch that their head goes forward, it increases the pressure on the patient's neck or the person's neck to 32 pounds of pressure per square inch. And if they bring their head forward another inch, that will increase the pressure on their neck another 10 pounds pressure per square inch, making it 42 pounds of pressure per square inch on a person who weighs 120 pounds. Now the pressure on their low back is tenfold their body weight plus the 42 pounds. And in this case, that person's pressure on their back is over 1,000 pounds of pressure per square inch. So no wonder why you always have neck pain and back pain when you have bad posture. So if you get anything out of this lecture today, it's really important that you understand having good body mechanics and having the therapists that work with you understand that they really need to work on your posture and your body mechanics before you do just about anything with them. In the picture on the left, where it's the skeleton with the red lines going through it, you can see the curvatures of the spine changing. In the neck, you should have a lordosis, a little curve in your neck to take the pressure off your head when it's resting on your neck. And in this case, the patient's neck is forward, which is causing that cervical spine to straighten, which will cause the muscles behind the neck to go into muscle spasms. That will give you that kyphoscoliosis, or that hump back in your thoracic area, and will cause your low back to flatten as well and push your hips forward and make your buttocks muscles weak and your hamstrings tight, as well as making your hip flexors tight. And so you end up with having a lot of biomechanical and musculoskeletal deficits because of having bad posture. So if we can fix the posture, we can take care of a lot of pressure on your neck and your back and take care of some of your musculoskeletal pain. Now, this is Jen. She's a patient that we treat here at Healy Physical Therapy, and this is how she was sitting the first day she came into therapy. Slouched, side bending over to her right, her head was side bent to the right and turned to the left. You can see her in the front view and from the side view. Now, I'm going to show you an exercise that Ed's going to demonstrate in this video that I'm doing. But if you are a patient that has shoulders that sublux or dislocate, please don't do this exercise. If you don't have shoulders that sublux or dislocate, you can do this exercise with us as I'm talking you through it. So when I do this exercise with my patients, the first day I start off with them, I like to put them in front of a mirror so they can have some proprioceptive feedback by the mirror. I have Ned sitting on a treatment table. I have him putting his feet flat on the floor. His hips are slightly higher than his knees. His feet are flat on the floor, as I said, and his knees are opened, hip width. His palms are facing each other, And I'm in the background in the mirror so that he can see me as well. Now what he does is he lifts his hand straight up over his head to where it's comfortable with his palms facing each other. And after that, he's going to turn his knuckles towards each other with his arms over his head. After that, he's going to slowly bring his elbows down and slightly back, which is going to engage his core and his scapular muscles behind his shoulder blades and help him sit up erect or sit up straight. I also have him exhaling as he's doing this because Ned has Marfan's, and I want to make sure he's not holding his breath and causing increased pressure inside his body. We call that a Valsalva if you hold your breath and you bear down while you're doing an exercise. So anytime that you're doing an activity with patients with Marfan's or EDS that has vascular, you always want to be exhaling when you're doing the activity, or any patient for that matter should be always exhaling. Now this is Ned's resting position after he did that 1 rep. His posture is perfect. And so with my patients with EDS or Marfan's, I'll have them do 1 or 2 or 3 of these. I'm not going to have them do 3 sets of 10 because it's just not appropriate for them to do that. A lot of times when they go to exercise, they can't do more than 2 or 3 reps correctly in the first place. So I don't want you doing these exercises if you're doing them incorrectly, nor do I want you to do them to fatigue. So I want to make sure you do it correctly so it will actually help and be beneficial. Now, Jen did the same exercise that I had Ned do in that video I just showed you, and this is what happened to her posture just after we did that 1 activity with her. She did about 3 to 5 reps. And this is how Jen sat on a computer with poor posture. There was a question that somebody sent through that they have POTS, they have dysautonomia, and they have difficulty with tachycardia. Jen and Ned have the same problem, and they were able to do these exercises when it was done in a controlled environment with me, making sure that they were breathing correctly. Now, if you're too dizzy and too short of breath, then I wouldn't start the exercise with you if it wasn't appropriate. So as you can see with Jen sitting here from that picture I showed you before, if her head weighed 12 pounds and she's sitting there in the chair, that's putting at least 32 pounds of pressure per square inch on her neck. And you can see how her back is. It's going to put a lot of pressure on her back as well. And she likes to go on the computer, so I wanted to make sure when she was working on the computer or reading that she was sitting in a good posture. And that's Ned when he first sat at my desk and he was doing some computer work for me. And a lot of our Marfan's patients tend to have some poor vision, so as you can see, Ned was hunting and pecking for the keyboard to make sure he was typing what he was trying to type. And that's how Ned was looking at the computer screen. As you can see, his head's forward and his chin is tremendously forward, rounding his back, causing some strain and stress in his back as well. You can see in the picture too, his knees are higher than his hips, which is putting his back curved and increasing the pressure on his low back while he's sitting there. And if you look at his chin, which I can't point to so you can't see it, you can see the muscles straining because his head's too far forward. Now, a simple exercise you can do in sitting is put your fingers underneath your nose on your top lip. And what you gently do is gently push your fingers back and tuck your chin in a little bit, or as you push your chin back, your fingers stay there and you're moving your top lip away from your fingers. I do not want you to put your fingers on your lower chin, because if you put your fingers on your lower chin and push back, you can actually cause some compression into your TMJ. And the majority of my EDS patients and my hypermobile patients with Marfan's tend to have TMJ dysfunctions or temporal mandibular joint pain. So if you push on the chin too hard, that's going to cause some pain into your TMJ and give you some other symptoms. So if you do this exercise, put your fingers underneath your nose on your top lip and gently tuck your chin back, and your fingers should go away from your top lip. Only do it in a very short position so that you don't add increased pressure on the back of your neck. Just a little tuck to take the pressure off the back of the neck and get you in a good position. After Jen was able to do that, she was able to get her chin in a good position while she was sitting. I put her in the chair and she was sitting up correctly. We got her in that position, and Jen was a little vertically challenged to the floor, so I put a little bolster on the floor so she'd rest her feet there so that her hips were slightly higher than her knees were underneath, right over her feet, so that she could decrease the stress and strain on her spine and her back. That was Jen's before picture and her after picture. And when she did that position as the after or corrected position, she was able to work on the computer for at least 20 to 30 minutes at a time. In the first picture, where she was sitting in a poor posture, she was only able to stay in that position and work on the computer for 2 or 3 minutes before she had to change positions because of pain. And this is what we did for Ned to get him in good position and to get his hips higher than his knees, with Ned being about 6'7". I had to put a pillow on the chair to make sure his hips were higher than his knees, which would take a lot of pressure off his back and prevent his back from curving. And it would get his head and chin in the right position. And your eyes should be about 19 inches away from the monitor, and your eyes should be in the middle of the monitor. Unfortunately, I'm 5'9", and my computer is set up perfectly for me, and not for someone who's 6'7" like Ned, but I was able to get him in a better posture so I could show this picture. Now, review the literature. If a patient does nothing, they won't get better with EDS, Marfan's, Lewy-Dietz, or any type of connective tissue disorder. The majority of the time, you'll get progressively worse, and you won't feel better. You'll have more pain. You'll end up with more braces. You'll end up with a lot of doctor visits and taking a lot of medication. What the literature shows that if you do exercise and exercise only, it is better than doing nothing. It's probably about 30 or 40% better than doing nothing. Manual therapy alone, without doing any therapeutic exercise, the literature shows that it's better than the therapeutic exercise by a little bit, and it's significantly better than doing nothing at all. The problem with just manual therapy, it feels great, and the therapist does all the work on you, and you're not doing anything. So when you get the manual therapy, you feel really good after you're done, but if you don't exercise and get those muscles to work correctly, then the treatment that the therapist did for you is for nothing, or it's useless, because your pain will come back within a couple of hours, if not a couple of minutes. The literature shows that if you combined manual therapy and correct therapeutic exercise, it is significantly better than doing nothing, significantly better than doing just exercise alone, and significantly better than doing manual therapy alone. And the statistics is something like 85 to 90% better. Now, the type of physical therapy deficits I see with patients that have hypermobility, Lewy-Dietz, Marfan's, Ehlers Danlos, they all have joint laxity and instability. They have muscle weakness from underuse and muscle weakness from prolonged muscle spasms. They have lack of proprioception. What that means is they don't know where they are in space. They have poor cardiovascular endurance, and they have poor muscle endurance. Now, the best treatment plan should consist of manual therapy, therapeutic core stabilization exercises, therapeutic joint stabilization exercises, proprioceptive or proprioception exercises, cardiovascular, and muscular endurance exercises. Structural manual therapy, and when I'm talking about the manual therapy that I do with my EDS patients and Marfan's patients, these are the tools that I use. I use muscle energy, myofascial release, Jones strain counter strain, cranial therapy, cranial sacral therapy, visceral manipulation and mobilization, and lymph drainage. I will also use zero balancing, which I did not have on this slide. Now I'm going to go through a manual physical therapy or osteopathic treatment session with an Ehlers Danlos patient and a Marfan's patient. This is Michelle. She'll be one of the speakers today as well. I'm doing a myofascial release to her rib cage and her thoracic paraspinal muscles. And my hands are on her spine in the back, treating her basically from around T1 down to L2. And the reason why I'm in this position here is T1 to L2 is where your sympathetic nervous system is in your body, and your sympathetic nervous system is the fight or flight part of your autonomic nervous system. So when you're in a lot of pain, your sympathetic nervous system is being overutilized, And so we need to get that to calm down before we can actually do a treatment. And a lot of my patients that I've seen from other therapists when they come into our clinic, that they've been doing just exercises, when their body has been in sympathetic overload, when you do exercises, that makes it worse. So we want to calm that down first before we start exercising. Now this is Ned, our Marfan's patient that I'm doing the same technique to, but on the opposite side of the body, so you can see it from both sides. Now I'm doing a pelvic floor myofascial release to Michelle to calm down the muscles in her pelvis. The same technique to Ned. I'm doing a sacroiliac joint decompression where my left hand is on the top of her hips, taking her bones of her two iliums and I'm moving them together, which is gapping her SI joint in the back. And I have my hand on her sacrum, and once I feel her sacrum drop into my hand, I can traction it gently down towards her feet. The same technique I'm doing with Ned, but instead of my hand on the side, my hand is between his legs, and I can hook onto his sacrum, and I can traction it straight down with my right hand as my left hand is moving his two iliums towards each other. Now this is a thoracic inlet release, which will help decrease a lot of chest and upper chest pain or rib cage pain in the front, will help in the beginning of getting ready for her to swallow. I'm also getting ready to take away some of the lower cervical and upper thoracic muscle pain that she's having. The same thing on Ned. The next technique I'm doing is a hyoid release. A lot of my EDS patients and Marfan's patients tend to have problems with swallowing and difficulty swallowing. So I want to make sure that the hyoid bone is balanced. And after I treat the hyoid bone, I will treat the cervical spine. And in particular, I always look at C3 because the hyoid bone is sitting just above C3 in the neck. So if the hyoid bone is off, I always want to take a look at C3 to make sure that that's balanced to improve the mechanism or the mechanics of the hyoid bone. Same thing on Ned. Now, when I'm doing a hyoid release on my patients, I will not let my patients talk. The hyoid bone is a really small bone, and if the patient's talking while you're holding on to it, it could potentially fracture, and I don't want that to happen, so I won't let them talk. If they have anything to say to me, they can tap my forearm, and I'll let go, and then they can talk. Now, this is a suboccipital release where I gently put my hands behind the occiput, and I can get the muscles that attach at the back of the skull to release and to relax and take some of the pressure off. And I'll add a little bit of distraction. Now a lot of patients, a lot of therapists get concerned when you have craniocervical instability or cervical instability when they're doing a suboccipital release to the patient's neck. I look at it like this. Your head weighs 10% of your body weight. Michelle is 100 pounds soaking wet, so her head doesn't weigh more than 10 pounds. So if I am not putting a traction force on her neck greater than 10 pounds, there is no way I can hurt her, because once she stands up against gravity, she's putting a tremendous amount of force on her neck. If I'm having her lie on her back and I'm adding a gentle traction, that is not going to cause any problem with any of the structures in the back of her neck, other than releasing the tightness that's there and decompressing it. And I'm doing the same thing to Ned, where I'm doing a gentle decompression on the back of his skull. Now, before I do all of this, I check out the two main ligaments that are supporting the C1 to C2, the alar ligament and the transverse ligament. I want to make sure that those ligaments are not ruptured, and if they are, they're going back to the neurosurgeon to have surgery. So I check both of those ligaments first before I do any of my cervical treatments with my EDS patients or Marfan's patients. Now, this is the start of craniosacral therapy. This is called a classic claw grip or a frontal release, where I'm lifting the frontal bone straight up and decompressing it. And this is and I'm doing the same thing on Ned. So you're getting to see a treatment on an EDS patient as well as a Marfan's patient. This is another type of frontal release where I'm using my finger pads and I'm lifting up her frontal bone. And I'm using intention with this, and I'm using my two thumbs. They're crossed, and I'm using the pressure of my two thumbs up towards the ceiling to decompress her frontal bone. And my fingers were only on the frontal bone. I'm not on any other bone. The same thing with Ned. It's a parietal release. Parietal release on Ned, and I am only on the parietal bone. Your two parietal bones, you have one on the right and one on the left. Those two bones are landlocked between the frontal bone, the occipital bone, and the two temporal bones. So you got to make sure that that bone's moving. I'm doing a sphenobasal adjunction or a sphenoid release. There was a question that somebody just asked, is every physical therapist trained in assessing the alar ligament and the transverse ligament? Yes. They should learn that when they're in college, doing their musculoskeletal rotation. When we do musculoskeletal, we learn this right after a patient has been in a car accident. You want to make sure we check those ligaments because usually those ligaments can rupture in a car accident where you have a rear end injury and the patient does a whiplash type injury to their neck. So every physical therapist in college should learn how to do an assessment of the alar ligament and the transverse ligament. And they're very easy to do. And I'm just doing a release there on Ned, sphenobasal adjunction. And somebody just asked me if I know a good physical therapist in Israel. The answer is no. This is called a frontal nasal suture release, where I'm balancing off Michelle's nose to her frontal bone. And this helps with decreasing some eye pressure and decreasing a lot of the sinus pressure that my patients get. Also helps with some of the bags under your eyes. I end all of my treatments with what they call a CV4, which is a treatment to help relax and improve the cerebral spinal fluid flow. Your cerebral spinal fluid is produced in 4 places in your brain. And as physical therapists that are trained in craniosacral therapy, they know how to do that to improve the flow of the craniosacral fluid. And I like to end this one with a CV4, which is very relaxing after I do the treatment. No, I do not know a therapist in Argentina as well. Now, this is a muscle energy technique for Michelle's occiput and her first cervical vertebrae. That was out of alignment, so I'm doing a muscle energy technique for that. The therapist has to diagnose which position the bone is stuck in, and then they have to do the muscle energy to treat it. Once I figure out the position that the patient's occiput and C1 is stuck in, I like to teach all of my patients a self-correction for the way the bone is dysfunction. This picture is for a very specific pathology where the patient's occiput and C1 is side bent to the right and rotated to the left. Michelle would lift up her left foot, flex it towards her nose, and bring her eyes to the right, which would help balance that dysfunction. Now, if it was the opposite and the patient was rotated to the right and side bent to the left, at her occiput and C1, then she would lift up her right leg, flex the foot, and bring her eyes to the left. Now, this is a muscle energy for Michelle's low back, her L5. She has a facet joint problem there, and I'm doing a muscle energy technique to correct that. Now, in this case, you can see my left arm is holding her right knee, and my bicep, the forearm, is holding her foot. My hip is holding her knee, and my hand is holding her back, so nothing will sublux or dislocate. And Michelle would be pushing her foot directly down towards the table with about 3 to 5 pounds of pressure, which will allow that L5 to slide back in place. This is the same technique on Ned, but Ned is almost twice the size as Michelle, because Michelle is 4'11" on a 4'10", and Ned is 6'7". So in Ned being a lot bigger, I have to use my hip and my body to hold his knee and his shin in place so that he doesn't sublux his joints, while my forearm and my hand are supporting his hip and his spine, and my left hand is taking the resistance as Ned is pushing his foot down into my hand. We want to make sure, obviously, nothing gets subluxed while we're doing it. Now this is for a short leg, what we call an upslip, where Michelle's ilium slides up because of a tight muscle in her hip and a weak muscle in her hip. So she would push out into my hand, and then she would elongate her leg while she's doing it. It's an isometric contraction where the patient's muscle works to get the bone to move. In this case, I'm strengthening her gluteus medius to stabilize her hip and bring her leg down. I'm doing the same thing on Ned. The technique that you'll see a lot of therapists do, they'll stand at the foot of the table and hold the patient's leg and have the patient do a contract, relax, and at the end they'll manipulate the short leg and they'll hear a loud pop. With my patients with hypermobility, this is not a good idea. You could rip or tear the labrum in the hip or rupture some ligaments in the hip, so they should not be manipulating your hip if you have an upslip with Ehlers Danlos or Marfan's or any type of hypermobility syndrome. This is for a sacroiliac joint problem that Michelle had. It's for a left-on-left sacral torsion. In the book, it tells us to stand in front of the patient to do this, but to protect my back and to make Michelle feel more comfortable, and I wanted to protect her hip and her knees, my left thigh is supporting her knees and her hip, and my left hand is supporting her back, and she pushes both of her feet gently up into my hand. And it's the same thing on Ned, but Ned's legs are really heavy and he's strong, so I didn't want him to use too much pressure with his legs, so I'm just resisting the bottom leg as he's pushing up both legs gently towards the ceiling. And this was Michelle on the left where it says pre-treatment, how she looked before I did the treatment, and this is how she looked after I did the treatment, post-treatment. And that's when we would start some exercise with her when her body is aligned and in good mechanics, so that her body can tolerate the exercises. And this is a picture of Ned where it's pre-treatment, what he looked like before, and a picture after. You can see the difference in his posture and how tall he was standing compared to the prior one. That's what he looked like before the treatment. That's what he looked like after the treatment. That's a side view and a side view. Drastic difference. Before view, after view, or post-treatment. Now these are the exercises that I start with my patients with Marfan's or EDS. Now I'm having him making sure he's breathing correctly, because any of my patients with Marfan's or EDS or any patient, whether they have connective tissue disorders or not, I want to make sure that they're breathing correctly. If your diaphragm is working correctly, it will help perfuse more blood flow from your heart by about 30% more. So if you're breathing correctly, you're going to get more blood flow, which is going to help in the healing process. Secondly, if you're breathing while you're exercising, you're not holding your breath, so you're not increasing any pressure inside your body, which is going to cause issues if you have any aneurysms. We want to make sure you're breathing and not holding your breath. So we made sure that Ned was breathing correctly before we started. I put my hands on his belly to make sure he was diaphragmatically breathing. So he'd inhale, my hand would go up. He'd exhale, my hand would go down. Once he got that down, I started to teach him what we call a pelvic neutral, where he's engaging his lower abdominals as he's breathing and stabilizing his pelvis. It's a short tilt back. It's not a complete posterior pelvic tilt. The posterior pelvic tilt is where you push your back and your sacrum into the table. A pelvic neutral is where you engage the muscles and find a position for yourself where you have no pain. And then we want you to exercise in that position, in a position of no pain while you're contracting your abdominals. The reason for that is, if you're having no pain while you're exercising, your brain is teaching the muscle how to work correctly and not work while it's in pain. If your body is in pain, it will do anything and everything to get out of pain and causing you to do exercises incorrectly. So I want to make sure that my patients are exercising correctly, and while they're exercising, that they have no pain. Now this is Ned doing a ball squeeze to increase the strength of his leg muscles and to stabilize his pelvis after I do muscle energy. He's also doing a pelvic neutral. This is Ned doing a bridge. While he's in pelvic neutral, he's also exhaling as he lifts up. Now this is more advanced. Ned is doing a ball squeeze like you saw earlier and a bridge at the same time. This is a more advanced exercise as he's exhaling. This is a more advanced exercise where he's in pelvic neutral, doing a bridge, and doing a straight leg raise at the same time. Now this is what we call the dead bug, where he's lying on his back and he's doing opposite arm and leg motion while he's maintaining pelvic neutral and breathing. These are much more advanced exercises. Now he's lying on his back, lying on his belly. I have his neck supported with a towel roll so that he's not going to get any stress in his upper back or his neck, a pillow underneath his belly to protect his back, and his wife is diligently watching, making sure he's not cheating. He's lifting his leg about 2 to 4 inches up off the table while he is maintaining pelvic neutral. Now, Ned is doing the opposite. He's got his head supported, pelvic neutral. He's lifting his right leg and his left arm to increase strength throughout his entire back. This helps my patients walk better because when you walk in a reciprocal pattern. Opposite arm and leg go forward. Now, this is called a multifidus exercise, or basic multifidus, where Ned is in the quadruped or on his hands and knees. His hands are shoulder width apart. He's in pelvic neutral. And he's deloading his knee from the table, his right knee, not his left. You can see his left knee is compressed into the table, as you can see his left hand and his right hand. So he's deloading the left knee slightly up from the mat, which will help strengthen the muscles in his back, what we call multifidus muscles, which help stabilize your spine. It's a very important exercise to do. As you can see, Ned is really tight in his upper back, where he has a hard time lifting his arm past 90 degrees. So he's in pelvic neutral and he's lifting up so I can strengthen the muscles in his shoulder area in the back. We call your scapula stabilizers. I'm standing there making sure he's in pelvic neutral with my hand supporting his back to make sure his sacrum and pelvis is staying level. My left hand is on his belly, making sure he's in pelvic neutral. As he straightens out his leg, he's also exhaling. He's maintaining good neck position, so he's doing a slight chin tuck, which is also strengthening his neck. Now we're doing opposite arm and leg. We call this bird dog, or alternating upper extremity and lower extremity extension while he's in pelvic neutral. Now I'm challenging Ned more without me contacting him to make sure that the stick doesn't fall. He's maintaining pelvic neutral, he's not dropping his pelvis, and he's lifting his opposite arm and leg, and he's breathing. I'm having to do some standing exercises now where he's going to strengthen the side of his leg muscles or his hip muscles while he's maintaining pelvic neutral and using the bar for balance. It's called hip flexion, so he's going to engage his core and his hip flexors as he's standing in pelvic neutral. He's doing some hip extension to strengthen his low back and his buttocks and his leg. You can't see this, what he's standing on. He's standing on a platform. Underneath this platform is a big air balloon. It's called a BOSU. So he's trying to balance on this balloon that's on the floor while he's maintaining pelvic neutral. He's using his hands on the wall. After he gets his balance and he feels good, he's going to bring his elbows back or squeeze his shoulder blades together as he's standing up to do a higher level exercise. So he's doing a strengthening exercise with proprioception. Now this is part of the cardiovascular. I like to start my patients on a recumbent bike, which has back support. It also has a cardiac heart monitor here, so I can tell how much his heart is working. With my EDS patients or my Marfan's patients, if they have cardiac issues, I like to keep an eye on their heart rate. And if it's appropriate, we can put him on an upright bike, and you can see Ned was maintaining good posture while he was doing some cardiovascular exercising. Now Ned's sitting on a ball. You can't see it, but you can see it in the mirror over here. This is called a physio ball. It's filled with air, and he's balancing himself on the ball in pelvic neutral, getting a good posture. Once he gets in good posture, I'll have him do some exercises. He's lifting both arms up over his head. Increase some extension strength. I got him lifting his right knee up off the floor, his foot up off the floor, so he's lifting his right knee, which is going to cause his balance to shift, and he's got to maintain his balance with his pelvic neutral. So it's more challenging balancing and coordination exercise. He's lifting up his right knee and his left arm. I have him straightening out his right leg while he's balancing on the ball for more coordination and proprioception and strengthening. He's straightening out his right leg and his left arm, doing some more strengthening. Now I have him on a ball balancing in pelvic neutral, maintaining good head position and make sure he's exhaling. He's in pelvic neutral, making sure his buttocks doesn't drop down to the floor. I have him do a little bit of a sit-up as he's exhaling. You can see me working with him, making sure he's exhaling I'm exhaling with him to make sure he's doing it. I have his legs up on the BOSU, on the physio ball, and I'm having him do a bridge, maintaining pelvic neutral. Now, all of those exercises you saw with Ned, I started him off really slow, and he was able to progress through all of those exercises after working with him for quite some time. Now, this is Michelle. She's in a Miami J cervical collar. She had some craniocervical instability and cervical instability. So once I got her neck aligned, I wanted to start some gentle strengthening exercises with her. So I had her sit up, and I tried to do some strengthening exercise with her. The first thing you see is I'm supporting her elbow and her arm so she doesn't dislocate or sublux her arm, and she's gently bringing her chin down towards her chest. As you can see, her fingers are bowing, and that's what I'm looking at. I want to make sure that her fingers don't bow because I don't want her to have any issues with the joints in her fingers. So I want her to contract less pressure than she was doing there. So I was trying to get her to do that. Now, if that becomes a problem, then I would lie her down and do it a different way. Now, this is a picture of Amanda. She's wearing a Vista cervical collar. She had cranial cervical instability as well. And you can see between the opening of her cervical collar that the muscles in her neck are getting stronger by her gently bringing her chin down towards her chest. Now, this is Michelle when she was having, we got her out of the brace, and I had her gently turn her eyes to the left. As you can see on the right side, underneath her earring and going down across, her sternocleidomastoid is strengthening or firing when she turns her eyes to the left. If she turns her eyes to the right, the left sternocleidomastoid will work or fire. So I like to stop my patients with some eye motions. Now, if the patient has increased eye pressure with the eye motions, I won't do it, or I'll try and have them back off and not turn the eye as far. But I want to make sure that if they're doing the strengthening exercise, they're not getting any pain or eye or head pressure. In this case, the next step for Michelle was to turn her eyes and gently resist with her fingers. And as you can see in this picture, Michelle learned well. Her fingers aren't buckling or bending. So we were able to do this exercise with her. You can see her right sternocleidomastoid firing quite nicely in that picture. Now this is Amanda. When Amanda first started with us, she could barely bridge. She had to wear her neck collar and be supported with a pillow. Once we got her going and we got her stronger, she was able to do the exercises and support her own neck on the mat, her shoulders quite well, and you can see she was lifting twice as high. You also see that her belly became much firmer in the post-treatments after she's been here a while than before. This was Amanda on her first time with us when she was trying to do straight leg raising. She could barely get her leg off the table, and we supported her neck with the Vista collar and her pillow. And then as she got better at it and stronger, again, she didn't need the pillow or the cervical collar, and she was able to lift her leg up nice and tall. This is some shoulder stabilization exercises with Christine. In the beginning, we were doing some exercises with her, and I wanted to make sure that her shoulders were at 90 degrees and she wasn't subluxing or dislocating her shoulders. As she got better at it, we added a 1-pound weight with it, and she was holding pelvic neutral as well. Had to do some bicep curls to strengthen her arms and pelvic neutral with the 1-pound weight. I had her doing some third tubing scapular stabilization exercises with the tubing. And I had Amanda on a ball doing some abdominal strengthening. And these are the proprioceptive exercises where I have Jen doing some balancing and coordination exercise on one foot. She's on a BOSU ball doing a mini squat. Standing doing a hip flexion to 90 degrees on a BOSU ball. And Christina on a recumbent bike and on an upright bike to do some cardiovascular exercising. That's an EDS patient. And these are the self-corrections I taught Michelle to fix her first rib and to fix her SI joint. All right, now I'm going to turn this over to Michelle to talk for a minute or two, and then Ned.
Hi, this is Michelle. I was diagnosed with EDS back in 2011 when I was 35 years old. It was a long and arduous process to get that diagnosis. Along the way, I went to several different physical therapy clinics attempting to treat specific injuries like knee dislocations or frequent ankle sprains, as well as generalized chronic neck pain that had been triggered by a car accident in my early 20s that never abated. Not a single one of these experiences was beneficial. In fact, upon being discharged in every instance, neither my strength nor my pain level were improved. Still, because I couldn't progress through the traditional exercises they were having me perform due to increased instability and muscle spasms, they essentially would give up on me under the guise of insurance companies needing to see progress. Left with no other options and being told by several doctors that I should hold off on exercising until they figured out what my diagnosis was, I found myself getting increasingly deconditioned, which only led to an increase in injuries and pain. I found Mike Healy at the EDS Society conference in Providence, Rhode Island. I went to see his lecture despite the fact that I had given up all hope on PT. But my daughter had EDS too, and it hadn't ruined her body yet. She was still in her teens. So I wanted to hear what someone who had actually heard of our disorder before had to say, and someone who had actually treated people with EDS. And I was really surprised during his lecture. He basically told my story, only it wasn't just my story. It was the story of many EDS patients and their failed PT experiences. Since seeing him, I can tell you that it was difficult at first, but at this point, I've been seeing him about 5 years. He's gotten me through 3 different surgeries that had nothing to do per se with EDS, just other complications that occur along the way with age. But at this point, I am definitely more functional. I have less dislocations, definitely more stable. He's taught me so much about my body and the different things to expect. Proper alignment's given me the ability to get stronger, gain stamina, be more functional. It's not a cure. I still have some dislocations. I still live in pain, mostly from muscle spasms. But at the same time, I'm improving a lot more, and I have hope because I have a good set of therapists here that can help with the different things that come up along the way. And it's taught me a lot about how to protect myself from being injured more. And that's important. So that's how PT has helped me.
Hi, good afternoon. I'm Ned O'Donnell, and I suffer from Marfan syndrome. It's very hard to add anything to what Michelle had to say. What I found striking as she spoke was that the story of someone who suffers with Ehlers Danlos, the misdiagnosis and the other kinds of treatments, is very much, but hopefully less and less frequently, the story of someone who has Marfan syndrome. I will tell you that I stay very close to the good folks at Johns Hopkins Hospital, which is the center of excellence for people with Marfan syndrome. And I also stay very close to Mike. I stay very close to a physical therapist who understands the disease and understands what I can and can't do. I hope everyone who listened to Mike's presentation can appreciate the nuances between treating someone without a connective tissue disorder and treating someone who has a connective tissue disorder. Those differences are very, very critical to not exacerbating our conditions and actually doing what the goal of physical therapy is, which is making us self-sufficient. So what I was able to do with the physical therapy that I got was regain my confidence in my body that it wouldn't fail me, and that I could actually go back to the gym and do the kinds of exercises that I absolutely love to do, remembering that I can never valsalva. I have to breathe through my motions. So exercise is critical. It has to be part of our existence. I would simply close by thanking all for the attention to this disease, because the knowledge is the thing that prevents the misdiagnoses that Michelle and I have suffered with for so much of our lives. Remember that we always have to be mindful of our Marfans and our Ehlers Danlos, but we can't let the disease define us. We can't let it make up our minds about who we are. Thank you.
So thank you, Ned and Michelle and Michael. I know Michael's got a couple more slides left. There's a little more time, but I want to make sure we I don't want this to end without us saying goodbye. So the last few slides are about finding the right physical therapist, and we actually, Michael wrote a blog post for us on that. So we will send that link out with our follow-up to this webinar. And I know you guys have so many questions, and Michael shared so much great information with us that I have the questions and we will address those, but we're not going to have time to do that right now, unfortunately. I just want to let everybody know if they have other questions, you can obviously go to Jen Lynch, the nurse in our Help and Resource Center, and there's her information, and also our website, marfan.org. Michael is a great resource for us, and any questions that you have that Jen can't answer, he will be helping us out answering those as well, like I said, as everything that you submitted ahead and what you've submitted during this call. Our Marfan and Related Disorders Empowerment Series continues next month with a talk on Social Security disability on February 27th. Any suggestions that you have for future topics, you can send to me or to my colleague, Susan Leshin. And again, I want to thank Michael Healy for giving us this super, super informative talk today, and to all of you for participating. Michael, do you have any final words?
Yes, if you want me to answer one question, I will answer the one about wearing the braces.
Okay, one question, and if he gets cut off at 4 o'clock, I apologize for that, but go for it.
All right, but first, if you saw one of the first slides, there is a little slide on there that says HealyPhysicalTherapy.com. If you have any questions for me, please send an email to that, and I have somebody who's looking at that every day, and she gets me the questions, and I will answer them directly to you if you have them. There was a question from somebody that says, this is for you or for an orthopedist. What is your opinion about wearing a supportive brace as part of pain management? Specifically, do you agree with the cause of muscle atrophy thereafter, or best avoid? My feeling on wearing braces is this. It's important that patients have enough stability in their body, and using the braces will help with that and protect your joints. However, if you are not exercising, it is not a good idea to wear braces for a long period of time, because your muscles will atrophy and become weak. And when you get out of the brace, you'll have more problems than when you were in the brace before, or before you went into the brace, you'll suffer from more problems. So if you are wearing a brace, make sure you're on physical therapy. And as Ned said, it's really important to make sure that you're exercising. If you're not, then I would not have you wear a brace until you were in therapy exercising. Okay.
Okay, well, thank you very much for that. And thank you, everybody. I do want to end by 4 o'clock, so we are about there. So thank you so much. We'll go through all your questions, and we will put those together and let you know where you can find the answers. Thank you again. Hope to see you at the next webinar.
Thank you again, Eileen, for inviting me.
Okay. Okay, thanks, Mike. Bye, everybody.